Good afternoon, everybody. I have no disclosures. So as we know, enhanced recovery after surgery pathways include multiple interventions throughout the perioperative course. And we often refer to adherence to the single interventions. And what does that mean? That means that a patient actually completes a planned intervention. So for example, if the patient was planned to receive a laxative on the first day after surgery, the patient actually receives it. We also often refer to overall adherence of the pathway, and that actually refers to the number of interventions to which a patient is adherent throughout the perioperative course in the pathway. And for example, in a 14-element pathway, if the patient was adherent to 11 elements, that would be a 78% overall adherence rate. In the last few years, the importance of overall adherence has emerged, and we have different studies that have shown that increasing adherence is linked with improved recovery. However, almost all of the studies that have been published have focused on postoperative outcomes that are very traditional, so clinical outcomes, such as length of hospital stay and complications. But these outcomes do not capture the complexity of the process of recovery, and they also lack the patient perspective. As we know, recovery comprises multiple dimensions of health, and there's not a single measure that can capture the complexity of this construct. Recent guidelines advocate the use of patient-reported outcome measure to measure recovery after surgery. And if we look at the definition of PROs from the US Food and Drug Administration, this refers to reports of health status coming directly from the patient, generally in the form of a questionnaire. And they have different advantages. First of all, they allow broad assessment of health status across the different health domains. They also engage patients as the main stakeholders of the recovery process. So in our study, we wanted to evaluate to what extent the adherence to enhanced recovery pathway for colorectal surgery was associated with patient-reported recovery as measured by a variety of PROs, and also to identify if there were any key ERP elements associated with improved recovery. So how did we do this? We looked at our data, which was prospectively collected within a recently completed randomized controlled trials, 100 colorectal resection patients in 2014 and 2015. All these patients were treated within an enhanced recovery pathway, and we have a very well-established pathway at McGill University, and adherence was collected prospectively for 20 elements, which are included in this table. In our study, patients were assessed preoperatively within 4 weeks before surgery, and they were administered a variety of PROs. And postoperatively, we looked at the same PROs for early recovery at 2 days after surgery, and for late recovery at 4 weeks after surgery. So why did we choose certain PROs? So for early recovery, we looked at PROs that had a short recall period, so usually 24 hours, and that had elements that were applicable to hospitalized patients, because our target length of stay is usually 3 days. So most of the patients were hospitalized at the time. So we chose as PROs for early recovery, abdominal surgery impact scale, which was developed by Dr. Urbach and his group, the ASIS. It's an abdominal surgery specific PRO, which evaluates 6 domains of health and has an overall score between 18 and 126. The higher the scores means a better quality of life. We also examined fatigue-specific PROs, the multidimensional fatigue inventory, which takes into account 5 domains of health, of fatigue specifically, and gives specific subscale scores. And here, the higher the score, the more the fatigue the patient has. For late recovery, we needed PROs with a longer recall period, 4 weeks, and that were applicable to outpatient settings, as most of our patients had already been discharged at the time. So we used the publicly accessible version of the SF36, the RAN36, which is a generic quality of life questionnaire. It includes multiple domains of health, and we focused on the physical component and mental component summary scores. And then we chose 2 physical function specific PROs, the Duke Activity Status Index and the Life Space Mobility Scale. We performed a linear regression analysis to assess the influence of adherence to the pathway on the recovery as measured by PROs, and we adjusted for confounding factors such as gender, ASA score, surgical approach and site, stoma formation, and post-op complications. To address missing data, we used multiple imputation in our analysis. These are baseline characteristics of our patient. You can see that around 60% of our patients underwent surgery for malignancy, 37 underwent rectal surgery, and laparoscopy was completed in 81 of these patients. Basic clinical outcomes, you can see that the median length of stay was 3 days, and around 45% of patients had a 30-day complication. Looking at the adherence to single ERP elements, I'd just like to point out that the median overall adherence for the patient was pretty high. It was around 80%, which is 16 out of 20, and it was higher for pre-op and intra-op interventions, which is in line with current literature. Looking at the median values of median scores of our PROs, this is pretty interesting just to see that they actually do reflect the trajectory of recovery. And you can see that for ASIS, it does reduce compared to pre-op. And the same thing for the fatigue scale. Fatigue increases after surgery compared to the pre-op. There's actually no difference. They're very close regarding mental and the impact on motivation. Looking at late recovery, we can see that they follow the trajectory of recovery, especially those PROs that evaluate the physical component. Looking at our primary outcome, the impact of overall adherence in early recovery, we can see that with increasing overall adherence in the pathway, there is an increase of the ASIS score, and that is significant. So for each additional element of compliance to the pathway, there is a 4% increase in the ASIS score on postoperative day 2, significantly. While there is no difference and there is no impact of overall adherence on early recovery as measured by the multidimensional fatigue inventory. Looking at late recovery, we actually found no impact of overall adherence on recovery as measured by the Duke scale, the SF36, and the life space mobility scale. When we look at the impact of single ERP elements on recovery, we can see that for the ASIS, the postoperative nausea and vomit prophylaxis and the early solid food diet were significantly associated with improved recovery. While for the multiple dimensional fatigue inventory, we only had for the general fatigue subscale a significant effect of postoperative nausea and vomit prophylaxis. This is just to point out that it's very important. They're very well connected, the PONV prophylaxis and the early solid food diet, because they're pretty much prophylaxis for ileus and for bowel recovery. Before we get to conclusions, definitely our study has limitations. First of all, the PROs we used in the study were not specifically developed to measure postoperative recovery, apart from the ASIS. And we know that there is a lack of validated PROs in the literature evaluating recovery. And also in our study, we had a risk of selection bias, since this was not a consecutive cohort of patients, but they were patients selected for an ERCT. In conclusion, from the perspective of our patients, adherence to enhanced recovery pathway interventions for colorectal surgery does impact on early but not late postoperative recovery. And we don't know if it's just because of a lack of recovery-specific PROs, or it is because actually enhanced recovery only provides advantages in the shorter term and provides fewer advantages later after discharge. So this suggests that future research should focus on the development of recovery-specific PROs with adequate measurement properties. Thank you for your attention.